Don't let anyone make fun of you for making a birth plan. In this episode, we talk about the idea and energetics of writing a birth plan and all the various components to consider adding, as well as some philosophy on the flexibility of birth. We dive into various newborn and mother based interventions to be aware of so that you, your partner, and any labor support people can be on the same page in advocating for the choices you want for you and your baby. We cover a lot in this episode, so you may want to re listen or take notes. Let's dive in.
Welcome to Healthy as a Mother, the podcast for becoming and being a mother, with your co-hosts, Dr. Leah Gordon and Dr. Morgan McDermott, two naturopathic doctors who get it.
Each week, we teach you how to be the healthiest mother you can be, from fertility and preconception to pregnancy and birth prep, through postpartum and throughout motherhood, empowering you with the natural health guidance and education you're not getting elsewhere so you can confidently navigate the broken system at large.
The real, the raw, the untalked about.
And remember, this information is not intended to diagnose, treat, or manage any disease. Always consult with your doctor before making any changes.
All right, we are going to talk about birth plans today. And Dr. Morgan, this is your jam. And a lot of people just want to know, what is a birth plan? When should I make a birth plan? What should be in my birth plan? And why don't you just take it away and tell us what we should do?
Okay, so some people like to make fun of birth plans, and I just want to call that out right from the get-go because it is not silly having a plan and vision and wishes and wants for your birth experience. I feel like there is definitely a cultural thought out there that, yes, birth is unpredictable in a lot of ways, and so we need to be flexible, but that doesn't mean that we go in like willy-nilly with no preferences and no ideas, because sadly that is the way that a lot of people go into it, and then they're swept up in the system of a lot of choices that maybe they didn't even know were going to be given, or they didn't understand what was happening, and then walked away from the experience feeling really, to some level traumatized or just confused or disappointed, or felt like they could have done something different had they known. So I just want to say that right from the beginning, it is not silly, it is not naive to have a birth plan. What may be silly and naive is to think that every single thing on it is going to go exactly according to plan, because we just don't know. But we can try and be prepared the best that we can. And then whatever happens after that is, a mix of fate and circumstance. And then also you can, to the best of your ability with your birth team, make choices in real time that are still in alignment with your goals.
Yeah.
So that's the point, is being active and informed in your birth and not just allowing other people to make decisions for you that can really change the trajectory of your postpartum healing, your bonding with your baby, the way that you wanted to be treated. And it's such an intense experience, birth is, whether it goes exactly as planned or if it really shifts gears. If you have any feelings of fear or not knowing or understanding what the choices are and the various things that are thrown at you, it can just leave a really sour taste in your mouth, or even trauma. So birth trauma is, I think a lot of people are starting to really talk about nowadays, which is great. And I don't want that to scare anybody who's not had a baby yet, but we just need to know that it happens and that we can do things to prepare to prevent it. You know what I mean?
And I just will hop in here quickly because I know you have a lot to get through, but on my plan, I had a birth plan and it didn't go at all to plan. But I think because I had prepped and did all of the work that you're going to talk us through, I knew when I had given it my all and when I had done all of the things necessary. And even though I ended up in a C-section, I felt like I made that choice consciously and I knew my choices and my options. And that resulted in me not experiencing my birth as traumatic, even though a lot of what I went through, people would call traumatic in other situations. And so just like with fertility, having the ideal and having a plan, helping to focus on that in your mindset is really important because it sets the stage for your cells and for the environment. And we know, all of that is important. And also practicing surrender at the end of the day, surrendering to whatever is meant to be, but knowing that you have done what you needed to do. So tell us kind of what this all looks like.
Exactly. Well, and to your point there too, I feel like entering the motherhood space, for some people it's in the fertility journey, for some people it's throughout their pregnancy or during their birth, where we all sort of at some point or another, we all experience this moment where we're like, wow, okay, I really don't have control over this anymore. We're not dealing with just our singular woman self anymore. There's another person involved in this, and it can be humbling, to say the least, when you really want it to go a certain way. So in your sphere, it's the fertility world of people thinking, oh, I'm just going to have sex, I'm going to get pregnant, and then that doesn't happen. Or it can be with postpartum, them thinking like, I'm just going to put the baby on the breast and it's going to be fine and I'm just going to breastfeed. And then it's like, that's not how it goes sometimes. And so, birth can be that for a lot of women as well. But the sad and thing, in my opinion, is that birth can also be such an empowering experience. And although your birth did not go as planned, I do feel like you walked away. I remember you saying that your birth was beautiful. Like 2 days postpartum, you're like, I had the greatest birth. And I was like, I'm so happy you feel like that. Because as your doula, I felt like I failed you in some way. Because I did. But, we really, truly did everything. And we're going to have an episode where you share your whole birth story sometime too, because it was a really fascinating sort of learning experience for me too, to see us try everything. And she just really did not want to come out, and that's okay, But okay, so here's some of the things to consider. And it would be really good to get a pen and paper or pause this podcast throughout the episode so that you can write some things down, because we are going to cover a lot. Or maybe listen to it multiple times, who knows? Okay, so first of all, you just kind of need to decide what type of a birth you want to have. So do you want to have an unmedicated birth, meaning no pain medications, or no labor augmentation, meaning induction, like so using Pitocin or using some of the other, like the prostaglandin pills or a Foley bulb? There's lots of ways to induce. Do you want to have a medicated birth? Are you like, yes, I want to have an epidural? Because if that's the case, that's going to dictate where you birth, because you cannot have an epidural at a home birth or at a birth center. So do you want to use the water? Do you want to stay home as long as you can? Or do you how does it sound to get in the car and transfer to somewhere else mid-birth? So you have to ask yourself all these questions to be really honest. Like, do I want to do all that? Or where do I want to be? Because there's a lot of components that go into it. So then you decide where you want to birth. So what kind of birth do you want to have? What do you envision in your head? Because if you want to have a peaceful water birth, a lot of hospitals won't actually allow you to have the baby in the water, but birth centers and home birth can. So do you see what I'm saying? Like, you have to kind of figure out. So then you decide where you want to be. Your three options are home birth, birth center, or hospital birth. And one thing that I say all the time to people is that there is, in most states, now there is some nuances here between states, but they're very slight and not huge. I guess the same thing is not very slight, or they are slight.
You're not huge and so small.
Yeah, I just want to say it in multiple ways to emphasize that birthing centers, unless you live in like a small apartment or you live with roommates and you don't want them to be around, or you just don't like your house, or your house is really small, or you have other children and you want to leave or something, there's some other reason to leave your home, or you don't like your home, or it's not big enough. A birth center is really just like driving to someone else's house to have a baby. Midwives that can come to your home and midwives that are attending birth center births are going to have almost all, and this is where I say almost with a caveat that it does a little bit depend state to state, but most states, home birth midwives will have all of the neonatal resuscitation equipment that they need. They can carry IVs for saline bags, or even IV antibiotics, or sometimes they'll bring in injection antibiotics, like if you were GBS positive and wanted to go that route. They can bring oxygen to your house. So there's really no difference in terms of the medical difference between a birth center and a home birth in most states. So sometimes people think that a birth center is safer, or that it's different in that kind of a way, or that you're going to maybe be able to get some kind of level of pain relief that you wouldn't at home, but that's just not true. Unless you don't have like a big bathtub at your house and you can't get a birth tub. Then that might be true. Sometimes birth centers are really amazing and they have like ropes hanging from the ceiling, and you can like pull on all these things, and that can be cool.
Some aerial yoga while you give birth.
Yeah, exactly. And so that might be appealing, but I do just want to emphasize that there isn't, sometimes I feel like birth centers feel like a halfway point for people who want to do home birth, but they're for some reason still scared of that commitment. The one difference I would say is that a lot of the times too, birth centers are inside of hospitals. But that is kind of like the snake in the grass in a lot of ways, because they are right there. And guess what the transfer rate is of the birth centers that are inside of hospitals? It's usually very high. So you need to ask these kinds of questions in the locations of where you want to birth. So if it's your home birth midwife, interview 3 or 4 of them. If it's your birth centers, go to them, ask around, what are your transfer rates? How do you handle this, that, and the other? Their attitude and their vibe when you ask questions about like postpartum hemorrhage or shoulder dystocia or surprise breech will really be telling, because if they're like, oh my gosh, no, that's illegal here, we can't do that, then you know that you're getting your butt in an ambulance with a baby halfway hanging out of you, versus somebody who can just say, well, we'll just take it as it comes and we'll deal with it. You know, how much more dangerous would it be to call an ambulance in a halfway presenting breech than just to have the breech at home, even if it's illegal, like it was an accident, you know? Anyways, okay, I'm digressing. So then we need to decide with whom you want to birth. So if you're in a hospital, you don't have to always have an OB. So an obstetrician or an OBGYN, you can have a midwife in a hospital, depending on your hospital and where you live, of course, but they do work in hospitals, and that can be really awesome. If you are home or birth center, it's almost always going to be a midwife, but there are exceptions. Sometimes, like Dr. Stuart Fishbein in LA does home birth, and he's an OBGYN. So there is certain exceptions. Yeah, isn't that cool? Mm-hmm. And then their Victoria something is up in Orange County, LA, maybe Santa Barbara, one of those areas.
I know we had a friend who had a midwife and an OB attend her birth at home.
Yes, Dr. Stu was one of those.
Oh, cool.
Yeah, doctors. So he was awesome. He's just such a cool guy. He has his own podcast too. It's called Birthing Instincts. Okay, so, and then doulas always. So doulas, just for somebody who doesn't know, doulas are only support. They do nothing medical. They are not a midwife. They are not an OB. They are there to rub your back, bring you food, support your decisions, advocate for you, get you in different positions, remind you that you're strong and that you can do this. They are really there for the woman and the couple, if there's a partner as well, to just keep them chugging along and keep them feeling really confident in what's happening, and to uphold their birth plan. So a doula is really supposed to protect your wishes as things change. Maybe there is a transfer, or maybe now we're looking at C-section or something, and a doula can still really be there to say, well, she wanted to do skin to skin. Can we do that? And advocating for her and the baby in real time.
Perfect.
Okay, so a birth plan is usually just a couple of sheets of paper, and you're going to want to add some of the very basics to the top of, like, where you're giving birth, what your due date is, what your date of birth is, addresses and phone numbers of the doctor, the midwife, or the hospital, address of your home. Because here's the thing, like, you may be thinking that you're going to go somewhere, but your baby's born in the car. And it would be nice sometimes for people to have an information sheet on you and what's kind of happening if they can't, speak with you or you're in the throes of it. It's just nice to have, it's like an emergency sheet too.
So is this something that if you do choose to give birth in a hospital that you should give them?
Yes, absolutely. So you're going to give this to all the nurses. You're going to print out several sheets. Even if you're at home and you're planning a home birth or a birth center birth, keep a couple of extra sheets in like a purse, a bag, or your, emergency hospital bag if you were to transfer, so that no matter where you are, you have access to this thing, and that you can use it and give it to the people that are going to be around you. Or not you, probably your doula or your partner will be giving it. But yes, you want to print out several copies and make it easy to read, not too wordy. You can sometimes use little graphics and pictures, or just a couple of words like no pain meds, no episiotomy, etc. It can just be bullet points if you'd like. So you want to write down a couple of different categories of things. So some of the less like medical things that are often overlooked but are very important are your environmental wishes. So do you want there to be low lights? Do you want to have a diffuser? And you know what? Also, sometimes the birth plan is helpful for your birthing team, like your partner and your doula, to remember.
Yes.
Say it's a 2 or 3 day long birth and everybody's brains are getting a little bit oatmeal, and it's like, what are we talking about? Oh yeah, like she wanted to play this playlist. Let's put that on. So just throw all that information on there. Low voices, keeping the communications between the staff to like the staff and the doula, rather than having the nurses talk directly to the mom, things like that. Wearing your own clothing versus wearing the gown. Like, you can do that if you want to. You don't always have to wear that gown. Who's going to be there? So writing that down. So is it your partner or a friend, a doula if you have them, a photographer if you have them? So writing down those names. Also writing down, are you okay with students? Because if you're in a hospital setting, there may be residents that come in, and sometimes there's like 10 of them. And it's tricky for me because, when we were students, we needed to learn, and I get that. Like, I think I'm probably the type of person that if I was birthing in a hospital, I'd be like, yeah, send them in. I don't care. But as a first-time mom, though, no, absolutely not. And I would say protect your space very much. If you think you'd get heady about who is there and feel watched or violated visually or something like that, then say no. You can absolutely do that. But if you feel open to it, or it's, your fourth, fifth baby, something like that, you don't care. These people do need to learn. So it's a tricky balance there. But okay. So, and then another thing to add is your pain management plans. So if you don't want to be offered, it's like dangling a carrot in front of somebody. If your goal and plan is to not have an epidural or nitrous or IV pain meds, it is nice to not have them be offered all the time. And the nurses, I get why so this is again in the hospital. I get why they're doing it, because they want their patients to be comfortable, and it is hard to see people be uncomfortable and in pain. So they think that they're just sort of doing their jobs. But if you have a specific goal for various reasons, you want to be supported in that. And when they're just constantly asking you and you're in the throes of transition, it's going to be really hard to deny. So you can ask them, please don't offer pain medications. Or you write, I plan to get an epidural when I can. So then they can kind of be in communication with the anesthesiologist who's rounding and say, okay, they're getting out of surgery. She's 7 centimeters. Probably you're going to want to get your epidural now because he's going to go into another surgery soon. So he's not going to be available, stuff like that. If you do plan on an epidural, you need to tell them that, because sometimes the anesthesiologist gets booked up and then you can't get a hold of her. And then you're like, where's my epidural? And then all of a sudden your baby comes out. So you need to be ready for that.
Yeah,
okay.
smart.
Same thing like with birth and pushing positions. So do you not want to be flat on your back, which is a really common one? So do you want to be on your side or squatting? Who do you want to catch the baby? And this is also going to depend on your provider too, because some providers are going to be like, no, I don't, they're going to have their strong choices. And although they have their preferences and choices, it's your birth and you can do what you want. And so they may be telling you to get on your back and you can say, be quiet. I'm going to be here in the squat. And this is where your partner and your doula really help and advocate for you as well. Catching your baby or your partner catching the baby, who do you want to do that aspect? Do you want to be coached in your pushing, meaning that they tell you like, deep breath in. Okay. 1, 2, 3, 4, and they count to 10. Or do you want to have just intuitive pushing where you just kind of go and are not told? Sometimes you need a mix. So honestly, with my first birth, I didn't need it, but it did encourage me because I was at that point of like brink of exhaustion. So it did encourage me to have people kind of like chanting with me with the pushing. But that can also be a tricky dance, we're more likely to tear when we're being coached through pushing. So that's a known fact. We know that because you're not kind of listening to your body and panting then when the head is crowning and having a nice long slow crowning. So there's some, and you're increasing that pressure inside your body a lot when you hold your breath during the whole pushing. So now there's always been this, but I've seen it encouraged in hospitals recently, open glottis pushing, which means that you keep your throat open the whole time. Yeah, you don't block it off. You kind of like, but it's open. Like your glottis is still open. You're maybe moaning and making noises, but you're not blocking off that airflow. You are still exhaling throughout the push. So anyways, this is something you need to think about. I know this is going to be an episode that's packed full of decisions and choices that you need to think about. Yeah, because there's a lot here, So then your postpartum wishes, delayed cord clamping, which is where they wait a couple of minutes to allow all of baby's blood to flow through the placenta into the baby before they cut it off. So if they can do that, if there's not some sort of emergency situation, not to, because the baby needs to be, I don't know, I can't even really think of a situation because it's better for the baby. Even if they need to be resuscitated, they can resuscitate the baby on mom's belly while the baby still gets the blood and the oxygen from the placenta. But whatever, there's certain instances and stuff that
and
it's hard
one
to tell.
thing to just note on that. Yeah. One thing to note on that is that you can still do delayed cord clamping even with a C-section. So again, if it's like an emergency situation, but yes, the whole idea of delayed cord clamping is that the baby gets all their blood back. And a lot of babies who don't do delayed cord clamping end up anemic, and there's not a lot of iron in breast milk. So it becomes this whole problem. If you just let them get their blood from delayed cord clamping, it resolves a lot of that. And even if you do a C-section, you can still do delayed cord clamping, but it's usually a hospital policy whether they allow it or not. So it's something to ask, something I learned from my situation giving a birth in a C-section, that you can still benefit from some of these even if you have to go down that route.
Yes, and it may be something where they're like, okay, we can allow up to 60 seconds. Well, that's 60 seconds more blood than your baby would have gotten beforehand. So I think that that's better than nothing, you know? Okay, so then delaying the newborn exam, delaying bathing. Sometimes hospital policy is like, okay, they cut the cord, they whisk the baby away, they like rub all the vernix off, they swaddle them up, and they hand them back to you in this little swaddle, or they will bathe them within a couple of hours of birth, or maybe they do the newborn exam right away. But there's a lot of differences that can happen there. If everything has gone normally and no one's in danger, baby can go right to your chest. The newborn exam can be delayed for an hour or more, and you can have what's called golden hour. Golden hour is skin to skin. So, and even in a C-section, you can have golden hour where baby goes to partner or doula and is having, you know, some skin to skin with them, which is so beneficial and so important still while mom is getting sutured up and is getting put into recovery. Baby can still be with people unless they have to go to the NICU, in which case, like, okay, we'll deal with this later. But there's a lot of babies that don't go to the NICU that still don't get to have these things because people either just didn't know, or hospital policy sort of overrules wishes, which is really rare that it truly overrules wishes. Only in the case of danger or safety does that actually need to be the case. Otherwise, we just need to say and have our doula or a partner be like, no, give me the baby. I'm going to hold it while you suture her up. We don't need to have the baby alone in an incubator, or not incubator, but like on the table, swaddled, when I could be holding my baby. You know what I'm saying?
Right.
So,
which happened in my birth. I'm just going to keep bringing it back to my birth because,
yes, no, please do.
A lot of these wishes that you have in your home birth, if you have a home birth, a lot of these wishes come true. If you're in a hospital, is often when you're kind of like navigating whose authority is who and what are you doing. And so
Yes.
my husband was allowed in this operating room, and he ripped his shirt off as soon as she was born, and they tried to put her on me, and I had so much medication that I couldn't hold her. I couldn't do anything. It was honestly really sad. But my husband took her and did skin to skin with her right there in the operating room. And so I just want to say that these things are possible. You just need to either have the conversation with the doctor or hospital ahead of time, or ask these questions, or maybe you have a really cool hospital, you know, that you're birthing in, but just know that they are possible. Just because you're going to the operating room doesn't mean that everything goes out the window.
Absolutely. And one thing I will say, and I think I've said it in another podcast before, is just that the hospital can be scary and intimidating to talk to. It's almost like talking to the police. You sort of know your rights, you sort of don't. You feel like you're going to get in trouble. They maybe will intimidate you into feeling like something's wrong or whatever. And that's why a really good birth education course is super important, and having that support. Because yes, you as the mom may be really, really knowledgeable about birth, but when you're in it yourself, your brain goes somewhere else and you can't really be that person. So you need your partner and your doula, which I'm just going to continue to talk about as if everyone has a doula, because I really think that they should, at least for first births, because there's so much that you just don't know what's going on. And you don't need to be the one that's going to be so cognitive and heady and in that headspace. We don't want you to be there. We want you to feel super safe and supported and drop down into your animalistic brain and not have to think about any of these choices, and just know that the people around you are doing the best that they can to advocate for you. So, the golden hour is really important to establish breastfeeding as well. So we know that when people breastfeed within that first 30 to 60 minutes of birth, their breastfeeding rates are much more successful in the end. And so, not to say that it's not possible to breastfeed very well if that doesn't happen, but if we can, we want to try for it. So this is what I was talking about in the beginning, is like, we have our goals and our wishes on our plan, and then what actually ends up happening in reality will adjust as we need to. So that's kind of some of the main categories that we need to be thinking. And then now there's the various interventions that happen to baby and mom. So I'm going to go through them one by one. I'm going to start with the baby's decisions and the baby's interventions that can happen post-birth. So baby comes out. Immediately, as baby is coming out, actually, let's back up. If, ideally, nobody is like wanting forceps and vacuum. So I've seen it put on birth plans, no forceps, no vacuum. And I think that you can keep that on there, but it's usually going to be something that's talked about with you. Although I have heard, now I'm saying this, I'm walking myself back. I have heard horror stories where women, everything was going fine, everything was chilling, and then all of a sudden the doctor just whips them out and starts doing it really without any consent, without any discussion or education about, not education, but any just discussion or conversation like, oh, I think he's stuck. Let's pull him out. So you can keep something like that on your birth plan, which is like, why would we use these tools when we don't need them? Mm-hmm. So if you need them, then you need them. But if you don't, then let's not do that. Mm-hmm. So then the baby comes out. Suctioning. A lot of places have it as protocol that they just immediately suction the baby before they even allow 10 seconds to go by to see if the baby can clear the mucus on their own. And think about it, evolutionarily, babies can clear the mucus in most instances. Like, unless things, heart rate was dropping a lot before baby came out, or they came out and they're, white. So a blue purple baby is totally within the realm of normal. A white baby is not good. So that's a little bit dangerous. Like,
and
white,
that's different than the white from the vernix that is like the coating around
yes.
the baby. This is like their actual color of
skin
their skin
color. Mm-hmm. Yes, they look pale, ghostly white. Not good. The vernix, good question though. So that is another one that you need to decide is, do you want them to wipe off all the vernix? Because before you blink, sometimes all of it's gone. They've wiped it all off with towels. Now, to some extent, there's a little bit of stimulation that we have to give babies sometimes. So they'll rub their back with towels and they'll kind of rub them to stimulate them. But as much as we can, if you want to keep that vernix, we can do it in a way that's not wiping them down like a dog.
And there's benefits to all of these, which we don't have time to go into on this podcast, but all of these decisions are like, why would I care if my baby has white stuff all over their body?
Yeah,
like there's benefits to all of these things.
Yes.
And so we're not going to go into all of those, but just know that we're talking about the birth plan, but there are a lot of decisions to make of knowing what you want to say about all of these decisions.
Exactly. Yeah, good point. And I really can't go into every single little detail right now. I'll try to cover some main ones. So do you want your baby suctioned or not? Sometimes I think that we can just wait a minute and see. Although there's not a huge downside of being suctioned, it's just kind of annoying. Like, imagine being born and coming out and then all of a sudden there's like this hard metal, or not metal, plastic tube in your nose and you're being rubbed really vigorously. And we used to pick babies up by their feet and hold them upside down. Like, it's wild. It can be very peaceful and calm if everything is going well. So that's something to think about, whether or not you want to wipe them down or not. The delayed cord clamping, of course. What to do with the placenta. So do you want to keep the placenta? Do you want to encapsulate it or make a tincture later? Because if you do, you need to bring your own little cooler and they will double bag, you and your bags, bring some gallon bags, and they will double bag it and put it on ice for you in your cooler, but they will not keep it in a fridge in the hospital room or anything else because it's considered medical waste. And so you have to plan and take care of that. They will not have any part of that.
And you have to remove it before the day is over if you're in a hospital in most situations. So you
yes.
have to have someone come pick it up at a car.
Yes, they have
take
to come
it away.
Pick it up and take it away.
Which
they don't want
I know all about that as well. So
I know, it's funny. They really don't want it sitting there. And so if you're going to do something like just take it home and put it in the freezer to plant under a tree later, like I planned, and then I forgot and it's still sitting in my freezer, then, you need to make arrangements for that. So, okay, now do you want the baby to be bathed or not? So this is something that I will advocate very strongly. I can't almost think of any instance where we don't want to bathe, where we need to bathe the baby. If there's meconium, which is the first poop, or blood, wipe those little areas off with a clean, wet washcloth. But allowing a baby to sort of marinate and soak in the fluids and skin contact of you and nursing and being skin to skin for up 7 to 10 days before their first bath, I think is really ideal. So we want them to be inoculated with the good bacteria. Even a C-section baby, it's like, okay, now their first thing is going to mom or dad's chest. So allow them to be inoculated by your good bacteria and not wash them off. So I really advocate strongly for that. So now mom's decisions. Okay, so there's lots of decisions throughout the birth and postpartum that you'll have to decide on as well. So one of them is monitoring. So they're monitoring baby's heart rate. They can do it with a continuous fetal monitor, which almost no one does anymore, unless you have an epidural placed, and then you must. It's like hospital policy, they say. But again, I feel like you can advocate for yourself and you might have to sign an AMA, which is against medical advice. Although maybe you wouldn't want to in that, because there is risks to the baby with Pitocin and epidurals. And so maybe we do want to hear a heartbeat. But continuous fetal monitoring is those pink and blue bands, soft, stretchy bands. Although now I've been seeing that they're coming out with these Bluetooth sticker things that like stick onto the stomach. I'm not really sure how I feel about the Bluetooth aspect of that, but it is nice for mobility. Yeah, I'm not really totally sure about that yet, but they are kind of uncomfortable. They're a little bit restrictive. Once they're on there, your movement and your ability to adjust and shift does become affected. And if they slip off the heartbeat, the nurses are going to be constantly coming in and adjusting them. So there's downsides for sure. If you're not having an epidural yet or ever, you can do something that's called intermittent fetal monitoring, which is that for 20 minutes of every hour, they will come on and put those things on, the bands, listen to baby's heart rate, get a strip, which is like the little reading of the heartbeat and how well it's doing during your contractions, and then they'll take it off. You can also ask for and advocate Doppler only. So if you're at a home birth or a birth center, they will usually just be using a Doppler, which is, throughout your pregnancy and in your prenatal visits, they've been using that little wand and they'll just stick it on, listen for baby's heart rate for usually it's 1 minute, and they'll kind of calculate out what's happening. And they do that every so often. Sometimes they'll do it during contractions, sometimes between contractions. Then there's internal monitors. This would be in a hospital setting where they affix and they screw. It is a screw. They screw in a little wire into the top of baby's head. You have to be obviously a certain level dilated and descended for baby to be close enough for them to be able to do this. But they can screw that into baby's head and be checking. So I think that is really only appropriate in situations where we're really worried about something going on with baby, because that's pretty invasive.
Yeah, I was going to say, what did you do that for?
Yeah. Yeah. What are we doing there? Okay. Then the next is cervical checks. So some people deny cervical checks the entire time. Hospitals really don't like that. Midwives even sometimes don't like that. They want to know, kind of what's going on, especially when you start to push. They will want to know that you're fully complete, meaning you're 10 centimeters, so that you're not pushing up against cervix that hasn't melted away yet and getting your cervix all swollen. And so I can see why towards the very, very end, maybe there's a benefit, but it's also totally normal and fine. And women all around the world are birthing without any cervical checks. And so we need to be really questioning some of these routine interventions. When you are doing a cervical check, there is a lot of risk for things like infection, or if the water has not broken yet, then you are at risk for breaking the water prematurely, which can really speed things along in the labor. But also, if baby's not in the right position yet, can put mom in a position where okay, now your baby is posterior still, or asynclitic, meaning their head's off to the side like this, and you want to keep that water bag intact as long as you can. So it's protective for a lot of reasons. Then there's IV fluids. So some hospital policy, it's like we hook everybody up to some saline, or they'll do something like a hep lock. So they'll insert the beginning of the IV either into the back of your wrist or sometimes in your elbow, and they just tape it off. So there's no tubing is going in from a bag into it yet, but if they needed to, they could quickly hook it up easily. If it's an absolute must hospital policy, then hep locks aren't usually that bothersome. Although I have been at a birth before where the sight of the hep lock was so bothersome to her. It was more bothersome to her than her contractions.
Oh my gosh.
And she was wanting to just rip it out, and it was causing a lot of issues. So that one is kind of tricky. Again, you could just continue to try to refuse the whole thing, but sometimes hospitals are going to push back on you. Birth center and home birth settings usually will not bust out a saline bag unless it's really indicated. They're not going to do a hep lock on you in those settings most of the time. Okay, breaking your water or not. Like I was just mentioning, we want to keep it intact as long as we can. Other than, I would say when you're 7-8 centimeters and have been that way for a very long time and everything's chugging along well, and it's just maybe the bag is really buoyant and is causing a lack of pressure of the top of baby's head on your cervix to continue to dilate you. I think that in some cases it's appropriate maybe to go ahead and break it and see if we can move things along. I would not suggest breaking water at 2 centimeters, and I don't think anybody would do that, but just to say, I don't think that's a good idea.
Yeah.
Okay, so now antibiotics. You need to decide, are we going to do antibiotics or not? If you're GBS negative, they won't really offer you antibiotics unless you begin to have signs of a fever and infection. If you have signs of a fever and infection, then it's probably a good idea to get some antibiotics. Although we do need to know that epidurals can cause minor fevers. Epidurals can cause a little bit of a bump up in temperature that's associated with the epidural and not an infection. So we need to keep that in mind. But if other things are trending where, mom's pulse is going up and her blood pressure is going down and she's starting to get a fever and this is happening and her water's been broken for a long time, let's not mess around here. There is really big bad things that can happen to if it's an infection of the placenta or the chorion or somewhere else in mom's body or baby's body. You can deal with the after effects of the antibiotics later, but you don't need to get them prophylactically, meaning preventatively in all situations. Even if you are GBS positive, I encourage you to look into this a little bit because I feel like, thankfully, there's a lot of really good educational resources where it's pointing that, is it a good idea that we just give every single person who's GBS positive at 36, 37 weeks antibiotics when they're 42 weeks and we don't even know if they're GBS positive anymore, and you're giving them a bolus dose of antibiotic every 4 to 8 hours throughout their labor. Pretend this is a first-time mom and her labor is 36 hours. She's getting 4 to 8 rounds of antibiotics for that long of a labor, and it's like, we don't even know if she's positive anymore. So I don't know. We need to be asking some big questions about this.
Yeah, and there's some good probiotic strains that are protective for Group B strep. So Lactobacillus reuteri and rhamnosus, things like that you could be taking, prior.
Throughout your pregnancy, yes.
Yeah,
that's a good. We should do
Needed has a good oral probiotic that contains those, but that's something to chat about on another topic.
Yeah, but that's great. And you should talk about that with your provider of, okay, say you are positive at 36, 7 weeks. What can we do now? Or throughout your pregnancy to just prevent it in general. But okay, Pitocin is going to be offered as a method of induction. So that's going to be kind of taken, as the birth is going. But know that Pitocin has some downsides as well. And sometimes Pitocin is given in a shot form postpartum prophylactically to prevent postpartum hemorrhage, which is where you would have an excessive amount of bleeding. But sometimes they just do it routine, like baby comes out, they sort of do the delayed cord clamping thing. And then within 5 to 10 minutes of baby being born, they're putting a shot in mom's leg without there being any signs of a hemorrhage yet. And it's just hospital routine policy, which I really disagree with. Unless you have a history of postpartum hemorrhage, that would be really the only time that I think that might be a good idea. Otherwise, we should just watch and wait and see what's happening. Mm-hmm. And there's some other methods we can do as well, like get the baby breastfeeding and get that oxytocin flowing so that those contractions can clamp down, etc. So anyway, if you don't want that, you need to communicate it because sometimes it's hospital policy that they'll just do it. Saline. So saline can be good when you're dehydrated, especially for a long labor. If you are getting an epidural, you will also get a saline bag. That's because epidurals can lower your blood pressure. And so they give you saline actually before they place the epidural to pump up your blood volume so that you don't have that drop in blood pressure. But then throughout your epidural, they'll also run a saline bag. And if you're also going under C-section, you'll get a saline bag. The only downside about this, people would be like, well, it's saline, why do we care? But what we need to know about it, and I wouldn't say deny it for this reason, but I would just say keep in mind, you will have more fluid in your tissues. Baby will have more fluid in his or her tissues. And so babies sometimes can weigh more when they first come out, when there's been saline given to mom throughout the labor. And that matters. So say baby comes out as 7'10". Okay, well, now 3 days later, baby's 7 pounds or 6'10", seems to have lost a whole pound, and everybody's freaking out and your milk's not quite in yet. It's transitioning. Baby's been feeding around the clock on colostrum. Everybody's kind of worried now, and they're maybe thinking that it's too much of a weight loss, but really we need to adjust a couple of ounces for the saline induced fluid that baby has had. So maybe baby's true birth weight was like 7'6". And we don't actually really know how much to take off, but it's just something to think about. Also, mom can become more engorged when her milk does come in because of this excess fluid, and it can make it harder for baby to latch. So we need to be getting good lactation support around that. It's temporary. The fluid will go away, but we just need to account for it.
Good things. Good.
Okay. A couple more things. So, you need to decide and learn about all the different pain medication options. So there is the nitric oxide gas, which is something that you would hold up into your mouth and you suck and inhale and exhale into the mask the entire time you're having a contraction. It's not just like you breathe it and then you exhale into the room. You can't do that. It will make everybody else in the room feel affected as well. You have to breathe in and out of the mask, which I feel like is really difficult for a lot of people to do. But it can be helpful. It can kind of make you feel a little woozy too. So it just depends. I think it's a good bridger for like a short period of time, but I don't really feel like it's something that is a sustainable pain medication. Then there's IV pain meds, but that would be things like morphine, or sometimes they just give straight up fentanyl, which is really interesting.
Without your consent, without telling you at all that they're putting fentanyl in your IV.
Yep, and epidurals do contain some fentanyl as well. Sometimes there's a bit of a different mix, but there is a lot that goes into the epidural. And I know that a lot of people want to think that baby doesn't get the medication that's in the epidural, but they do. Mm-hmm. It's not going to, completely drug the baby out, but they do come out sometimes a little sleepier. Like, they're affected. There is a certain level of being affected. And there's still a time and a place for an epidural, whether it's you want it because you don't want to experience pain and pain is traumatic for you, or because you are so tired you have to sleep, or you just cannot go on. There are times. So I don't want this to say shame, but we need to have informed consent. We can't just act like it's all hunky-dory and the epidural doesn't affect the baby and fentanyl's not getting in there, and because it is. Yeah. And it's like, okay, well, we can take that information and use it then and make a proper informed choice. Like, okay, I understand this and I still want and need it. And that's okay too.
Yeah.
Okay, getting in the bathtub though, like in terms of alternative non-medicated forms of pain medication, getting in the bathtub, counter pressure, which is where someone's squeezing your hips, being touched, like light touch massage, and then a TENS unit. So we don't really talk about TENS units that much in the United States, but in Australia, New Zealand, Europe, especially England, Britain, what's the right word to discuss that?
I don't know. Great Britain includes more countries than just, who knows?
I've never known that. I'm really bad at geography. Anyways, a TENS unit is these little pads that go on your lower back, and they send an electrical pulse, and you have this little unit that you could hold or somebody could hold to send the pulses during your contractions, and it helps to override the nervous input that you're feeling so that the contractions feel a little bit less painful. Some women absolutely love TENS units. I would like to try one at some point. I don't think I'm probably going to go get one for my next birth here, but I do find it interesting. We just don't use them in the United States as a routine thing, but in those other countries, it's very routine. Mm-hmm. So, and that's another non-medicated form of pain management. Okay, so then with your vagina and as the baby is coming out, some things to think about: episiotomy. So episiotomy is where they make a cut in the perineum. So they'll cut your vaginal opening open a little bit more. I really only think this is appropriate if baby is super stuck or there's a shoulder dystocia and we really need to get baby out right now. But otherwise, we have learned over time that natural tears heal better. There was a time back in the day where they thought that episiotomy tears, so at a straight line cut, would heal way better than a jagged natural tear. But it kind of makes sense, right? Like a jagged natural tear is going to come back together and have all these little projections and fingerlings that when they heal will kind of make like a zipper and it'll all heal back up really well, versus a straight line is actually going to be less integritous over time. So we don't cut episiotomies routinely like we used to, but sometimes old timey docs might do it. Or I just heard a birth story recently where the woman had no clue. There was no reason to cut it. Everything was going completely fine. Baby was crowning and everything was normal. It was not stuck. There was no rush, and the doctor cut her and didn't ask her or tell her or anything. And the husband was just sitting there and it happened before he knew it. And it just,
Oh my God, that's insane.
And then the other thing is that when you make a small rip, a small cut, and baby comes out, sometimes it can tear even more, and you have a worse tear than you would if you had stretched slowly or torn naturally.
Yeah. Ugh.
So that one I would say is a no-go in most instances. Forceps and vacuum, like I already spoke about. I mean, nobody's really wanting those unless they need to. But again, maybe you talk with your provider that, hey, unless you have to, do not use these things on me. Mm-hmm. That should just go without saying. But again, informed consent is quickly dissolving in all parts of the world.
Totally.
So we need to be thinking about these. So yeah, that post-birth Pitocin, like I talked about, placental management. So sometimes I know it seems like I'm harping on hospitals, but there is a reason which is that they sometimes are just so managerial about everything, especially with placentas. So they like to wait maybe 10 to 15, maybe 20 minutes for a placenta maximum, but they start to feel really uncomfortable if the placenta doesn't come out faster than that. And I understand the reason is that if the cervix starts to close back up and placenta is not out yet, we're in really big trouble. And I get that. But sometimes it just takes placentas a minute to come out, and that's okay. So sometimes they'll do fundal massage, which is where they're pressing on your uterus and they're sort of tugging at the cord. And a lot of these practices are sort of looked down on now in the midwifery world because it's over management and it doesn't have better outcomes. We think that it does. We think if we mess with things more, we'll just will our way to control them. And it's not like that. So again, I can't speak for every single birth situation when I say these things, but just know that like it's okay in most instances to allow your placenta to come out. If you nurse the baby or you use nipple stimulation or you are, kept in a very safe, supported feeling bubble and you're not feeling traumatized by the birth that you just had, likely your placenta is going to come out just fine. So we just need to think about all these things. So cesarean decisions, if you are having an emergency cesarean, at that point, it's sometimes life or death, and you just have to kind of deal with what's happening and the after effects later. There's not a lot of say you're going to have in that scenario, and you really probably shouldn't or couldn't anyways, because they are just going to do what they need to do. You see what I'm saying? But if it's a gentle, planned cesarean choice, or in the case of you, it was like, should we do this? We should probably do this. And it was slow and it wasn't emergent and everything was fine. Then there's these choices you can make. Like you could drop the drape down so you can watch the baby be pulled out. Or sometimes they'll use a clear drape. The delayed cord clamping when the baby comes out, immediate skin to skin on mom or partner when the baby comes out. So there's things that we should think about there too. And although I don't want people to really, really focus on having a cesarean if your plan is a vaginal birth, I do think it's important to have a little section on your birth plan that says, in the event of a cesarean, if possible, I would like, and then you just bullet point, delayed cord clamping, immediate skin to skin, drop the drape, like if we can, let's do it. Now, if it's an emergency, maybe that's not going to happen, but you see what I'm saying? Okay.
Yep.
Stool softeners and alternate or additional pain medications being offered post-birth. So if you are having a cesarean, one of the things that's very, very important postpartum is staying on top of your pain medication. And you should speak to this. Like, what was that like for you? Did you stay on top of it well enough, or did you not take enough and then you dealt with the repercussions later, or how was it?
So I was really good. Obviously, the first day or two, it all blurs together. And then I really wanted to go home. I was so tired of being in the hospital. They don't let you sleep. They interrupt you all the time. They won't let you sleep with your baby. And I would just do it anyways. And it was just whatever. But they said, I can't go home until I'm off these specific pain meds. And so I was like, well, I'll be fine. And so I was like, I'm ready to transition off these IV pain meds. And that was a huge mistake.
Oh, no.
And so I woke up in the middle of the night in excruciating pain. I had no idea. I mean, I never had a surgery before, and, being cut open in that way, it was just horrible. So I, pinged the nurse and was like, please, please. And she's like, well, we can't start you back on the IV meds. And so she tried to get me Tylenol, and it was just like a really bad situation. So yes, stay up on your pain meds. Don't let them lax. When you have had an epidural and you've had fentanyl, according to what I had, you obviously feel great. And so you just think, oh, I'm fine. I can totally heal and recover. And I think you just forget the cloud of pain support that you have over you. And so just, being mindful of staying up on it, because letting it lax, you can't, once the pain comes, it's hard to get back on top of it.
Exactly. That is the thing I think that people take away from their cesareans most is stay on top of it. And it might be like a week where you're really taking a lot of things, but again, it's temporary. And even if you're the type of person that doesn't like pain medication, you don't like taking medications, I get it. I understand.
Which is me. And I would never wish that pain upon anybody. So learn from me. This is the time and place. You just have to do it and just accept to the universe that everything's fine and your baby's not going to be a drug addict, even though you had fentanyl in your system, and it's fine. You're just going to be fine.
It's going to be totally fine. It is going to be totally fine. And, you'll transition off when you're ready, but you're trying to bond with your baby and enter new motherhood, not from a place of suffering as much as possible. So this is not the time to be super strong and get off. early,
Yeah,
you know,
it's
because
not. Stay up on
it's
it.
not.
Stay up on
And
it. Don't miss it. When you go home, stay up on it. Yes, 100%.
yeah, okay. I'm glad that I couldn't remember that aspect of your birth or not. But, and then the other thing is stool softeners. So, I like to have people take magnesium, but if you have been on some heavier medications with an epidural or a cesarean, you need something a little bit stronger because the effect of those medications is that your stool becomes slow. Your whole digestion slows down, and so constipation can be a really big bad thing. And whether you have an incision or you've had a vaginal birth, having a hard poop is not a fun thing. So we want to keep that stool really soft. You can do that with magnesium. Like I said, magnesium citrate would be probably the ideal form there, or something like a stool softener. So then just to close, my main kind of points here and some other tips are that this is for a flexible goal and wish list that we hope can be met, and we're not going to hold to it in unnecessary or inappropriate times. You know, I don't think anybody would do that. But if we can, we want certain ways for us to be treated. And I think that's completely normal and fine. So you're going to print several of them. You're going to give them to the nurses in the hospital, pin it on the board, or have your partner or doula remind new staff that are coming in. If you're at home, have a couple of them like in your near birthing space, have a couple in your bag in case you do have to be transferred. And also, one thing to write on it is thank you, and be really kind in your wording, because people are human. You know, these staff members they can get their feelings hurt or feel like you're being really kind of combative or just unfun to work with if you are super argumentative and combative in your wording. And so just being kind to the people around you, I feel like always increases your chances of being treated well.
Totally.
So,
Absolutely. You go way farther with honey than vinegar. And if nurses know that you're grateful and like you really care and like you're here to like have the best experience and like these are the things I want, but like please help me with them, like they're gonna go out of their way to help you sometimes.
Yes.
Sometimes they don't. But
Yes.
a lot of nurses are
But
wonderful.
yeah, but they get burnt out and they have bad days, and that doesn't mean that it's okay. But we can sort of hack that scenario and know that that's the case, and that sometimes birth is like a factory event in those settings. And so what do? Well, we just try to be really kind, and that's all that, you know, you can do in that setting. So anyway, I hope that was helpful. Again, you might need to listen to this a million times, and that's fine. But I just wanted to lay out what are the things that we're thinking about with a birth plan. Why do we care? What's the point? And then also know that you can hop on Google and get a lot of different examples of what they look like or how to organize the information and make it pretty, and, you know, put some time and intention into it, because this is your birth, man. Like, you got this.
Awesome. Thank you.
Thanks for listening to this episode of the Healthy as a Mother podcast.
In order for other women to hear this information, please leave a review with Apple Podcasts, subscribe, and send to a friend who could benefit from this content.
We're so excited to share more on becoming and being a mother next time. And remember, a healthier future starts now, and it starts with you.
Please remember that the ideas and views presented in this podcast are for informational purposes only and are not intended to serve as a substitute for medical care of any kind, including the diagnosis or treatment of any illness or disease. Consult with your provider before integrating this information into your own care plan. Now go have a wonderful day. You've got this.
Thanks for listening to this episode of the Healthy as a Mother podcast.
In order for other women to hear this information, please leave a review with Apple Podcasts, subscribe, and send to a friend who could benefit from this content.
We're so excited to share more on becoming and being a mother next time. And remember, a healthier future starts now, and it starts with you.
Please remember that the ideas and views presented in this podcast are for informational purposes only and are not intended to serve as a substitute for medical care of any kind, including the diagnosis or treatment of any illness or disease. Consult with your provider before integrating this information into your own care plan. Now go have a wonderful day. You've got this.